Hi, in this video we discuss the use of phakic lenses, how they are implanted, the indications, techniques, complications and their management. Now if we look at the entire gamut of phakic lenses available, the main indication for using a phakic lens is in those cases desirous of refractive surgery where a LASIK or a cornea-based surgery is either not feasible or desirable. This can be because of low corneal thickness or other problems. We can implant and correct the refractive error in myopia of about -3 to -25 diopters and also correct astigmatism up to 8 diopters. It is also available for hyperopic refractive errors. The other indications for using phakic lenses are in presbyopia, where a multifocal phakic lens can be used. Now this is the ICL or the implantable Collamer lens, which is now available with the Centra Flow technology that utilizes an aqua port right in the center of the optic for better flow of aqueous in the eye. This is a case with a refractive error of -19 diopter sphere and -2.575 diopter cylinder at 80 degrees in the right eye, and a refractive error of -14.5 diopter sphere with 3.25 diopter cylinder at 110 degrees in the left eye. Now obviously such high refractive errors are not suitable for a cornea-based refractive correction, and therefore we plan to do an ICL or an implantable Collamer lens. This is the pre-operative workup. Now for all phakic lenses, the pre-operative workup or the evaluation is the same. We have to do the keratometry, an accurate white-to-white horizontal corneal diameter using any instrument of our choice. A digital calipers is a good choice with the patient lying supine under the operating microscope. We have to do an accurate refraction, and we also measure the intraocular pressure. If required, we do a gonioscopy, and anterior chamber depth is calculated from the endothelium. This is very important, and we also do the standard topography, pentacam, etc. as are done for any refractive surgery. So now for a toric ICL, we have to do the marking or the reference marking at the slit lamp like we do for a toric IOL. This is the reference marking being done. This is the surgical video. Here we are marking the astigmatic axis as well as remarking the reference axis. Now different phakic lenses have different types of implantation. In the ICL, the toric ICL has to be implanted along a certain axis that is as calculated according to the worksheet. The cartridge is filled with BSS and viscoelastic. There is a special foam tip plunger that comes with the ICL, which is used to remove the ICL from its container as well as to load it onto the cartridge. We use this special forceps, toric ICL loading forceps, which is provided by the Star company, to position the ICL in the cartridge, and then the cartridge is loaded onto the implanter. In all phakic lens implantations, the surgical technique is fairly standard. In the beginning, we make a side port incision. We inject 2% HPMC as the viscoelastic, as it is much easier to remove and causes less pressure spikes postoperatively. We have to take care that we do not underfill or overfill the anterior chamber, and to ensure this, we see that the visible chains are seen in the anterior chamber of the HPMC. If these visible chains are not seen, that means we have overfilled the anterior chamber with the viscoelastic. And we implant the phakic lens, which is the toric ICL in this case. During the implantation, we have to ensure that the phakic lens is opened in the anterior chamber in a slow and gradual manner, and the direction has to be towards the iris plane. We do not have to go posteriorly like in an IOL, so that the phakic lens does not hit the lens or the anterior lens capsule. Once the phakic lens is fully open inside the anterior chamber, we then use some sort of a manipulating instrument like a haptic tucking forceps to position the haptics of the phakic lens behind the iris. After the phakic lens is well positioned, we remove the viscoelastic from the anterior chamber, recheck the position of the phakic lens if it is a toric phakic lens, and then seal the incisions just like in cataract surgery. And in our practice, we also routinely inject intracameral moxifloxacin into the anterior chamber. Now here we are showing the implantation of a toric IPCL from the Care Group India, which was the first phakic lens developed by an Indian company. This patient had a refractive error of -7.5 diopter with 1.5 diopter cylinder in the right eye and -7.5 diopter with a 2 diopter cylinder in the left eye. Most of the Indian companies now have custom designed phakic lenses, where we send the pre-operative data of the patient to the company and they send the custom designed phakic lens. Here again we are marking the reference axis on the slit lamp. This is the IPCL. We fill the cartridge with BSS and with viscoelastic, and we then place this phakic lens in the cartridge. The advantage with these Indian phakic lenses is that they are made of acrylic, unlike the ICL, which is made of porcine polymer, and so this is an easier to handle material. This is done under topical anesthesia, and if required we can supplement the anesthesia with intracameral lignocaine. We make the side port incision, we fill the anterior chamber with 2% HPMC, taking care not to overfill. We make the second side port and the main incision, and then we implant the toric IPCL. Once the IPCL has unfolded within the anterior chamber, we tuck the IPCL haptics or haptic pads with an IPCL manipulator behind the iris. Now here we show the resbiopic IPCL that is being used. This is a case of pseudophakia. The patient achieved a good distance visual acuity of 6/6 and was now desirous of getting freedom from near glasses. A resbiopic IPCL of 3.5 diopter ad from the Care Group India is being used in this patient. The loading of the phakic lens is just like the IOL. This is the resbiopic IPCL unfolding inside the anterior chamber. We tuck the IPCL haptics behind the iris. We ensure that we remove all the viscoelastic not only from the anterior chamber but also from between the two lenses. And then we seal the incisions and inject moxifloxacin. Now this is another case who has stable keratoconus, and keratoconus need not be the end of the road for freedom from glasses. Because the keratoconus was documented to be stable for the last 3-4 years, we decided to do a phakic lens implantation. In this case, an RIL or a refractive implantable lens available from the APA company was implanted. Again, the technique of implantation remains the same, and then implant the RIL. This case had an IPCL implantation done a year ago for -16 and -17 diopters FEAR refractive error with the cylinder. The patient now presented with cataracts. This is the cataract with the IPCL, as you can see. So we make the reference marking as for any toric lens implantation, and this is the IPCL being removed through a 2.8 millimeter incision. The cataract was fairly soft as the patient was young, and after removing the cataract, we are now implanting a customized toric multifocal IOL. This is the toric multifocal IOL being implanted within the capsular bag. So custom-made solutions and custom-designed lenses available from the Indian companies have saved the day in case of a complication like a cataract, which is quite dreaded after a phakic lens surgery. In the end, we are quite happy now that we have many custom-made solutions and custom-designed IOLs and phakic lenses available from the Indian companies, which provide spectacle freedom for a much wider range of patients at an affordable cost. Thank you.